First of all, I want to thank everyone for attending our session today, the mHealth Value Chain Opportunities and Barriers. My name is John Casillas. I'm the Senior Vice President of HIMSS, and delighted to be with you today. I'm also delighted to present our panelists. David Weirs is from Exton, Pennsylvania, and sits all the way to the right-hand side. David will be leading our panel discussion. I don't have any type of extensive bio for everybody. We're going to skip that so we can get into the meat of the session. After David, I've asked to provide, by the way, an overview of the mHealth area, the mHealth arena. I've asked Ishrat Hussain from USAID, Senior Health Advisor, who has just returned from a trip to Tanzania, where USAID convened a multi-country gathering to compare best practices, what's working, what's not, and she's going to provide the first report out of that week-long session, which I attended as well, and it was excellent, and I look forward to hearing her report. After Ishrat talks, Mira from the World Bank will be providing her perspective of how the bank is viewing mHealth and the opportunities or potential opportunities there for developing that capacity in the countries, in developing countries, especially around Africa. Mira is the lead health and nutrition specialist at the World Bank. And then David Delaney will be ending our session. David is the Chief Medical Officer and Collaborative E-Care Management and of Collaborative E-Care Management and Provider Solutions at SAP. And David will be providing case studies of mHealth in action in the North American segment. So it's going to be interesting to compare and contrast first world, third world. I really need your participation after the presentations. If you have questions, we would love to hear about them and address those at that time. So with that, I'm going to start with David Weir.
Good afternoon. Let me provide, as John mentioned, let me provide a bit of an overview, a bit of perspective with regard to mHealth, really as a framework to hopefully facilitate the follow-on presentations, but also, I think most critically, the discussion that we hope to have as part of the session going forward. Give you a bit of background with regard to the perspective that I bring to mHealth on a personal level, and it really is something of a mix in the sense that I've been involved both in hospital management and physician practice management here in the United States, as well as having had international exposure to health and health issues as part of working with a large multinational pharmaceutical company, coupling that with direct leadership role in, at that time, what was called a remote care management company, and now have the opportunity of working actually with a private equity firm here in the United States, which is looking to build out a capability in healthcare, both from an information and analytics standpoint, domestically, and then expanding that footprint into a multinational or global environment. So that is the perspective with which I bring. The remarks will initially focus on the United States, with some points addressing both Canada and the UK, the markets with which I'm most familiar. But I would like to think, at least in some of the basic points, there is applicability to markets on a global basis. And I hope that point will then come forward with some of the discussions that we have as a panel and as we can engage with you as an audience as well. I think one of the points that I want to highlight with regard to mobile health and the applications of mHealth, and I think this picks up very nicely in some of the conversations we've had today, is almost to create a dichotomy of what mHealth is and is not. I think that if one is to characterize mHealth, it is, in my mind, a facilitating technology. It is an enabling technology. It is a technology which can, I think, critically, if well structured and well deployed, and I think some of the discussions here today we'll touch on those issues, can lead to areas of enhancing efficiency and effectiveness with regard to the delivery of care, but also, I think, critically, taking a look at issues of integration and engagement. And those issues of integration and engagement as they apply both from the provider community as well as the patient community. Within that, however, there are three critical issues. One is scale. Whatever one thinks about with regard to mHealth, one has to think about the activities in the context of scale and the ability to achieve scale, because the next issue becomes payment. And if there is an overarching issue with regard to mHealth, and quite frankly, again, I can draw upon my personal experience in working in, at that time, what was called remote care management, it is the issue of sustainability and what constitutes sustainability from the standpoint of a business model, as well as sustainability with regard to enhancing clinical efficacy and effectiveness of care that is being delivered. And the third point is mHealth is not an add-on. If all one is looking to do is take existing care models and add on an mHealth component, you will fail. You will fail clinically. You will fail financially. And I don't think there's a great deal of a secret in that comment to anyone in the audience who's been involved in this field for a period of time. But again, I come back to the point that in its essence, mHealth is an enabling and facilitating technology which allows both the patient and the provider to fundamentally rethink the nature, orientation, and organization of care, and effectively, in many regards, become preemptive. So that, as opposed to delivering care services, one is in fact delivering health care. Within the context of mHealth, then, and the overarching framework that I want to think about is viewing mHealth as a component of an overall health care infrastructure. I know that we've talked a lot in the conference, and I apologize that I've only been here today, but I know in the sessions that I've seen today, we've talked a lot about the engagement with the patient. We focused a lot about the patient as an ultimate consumer in healthcare and enabling patients. I think there is a broader infrastructure and architecture around mHealth which has to be recognized as a component of an overall healthcare delivery system, and that delivery system being then applicable for multiple parties and multiple audiences. And that really relates to the mHealth deployment on an intra as well as inter-organizational basis. So the question becomes the role that mHealth can play in terms of facilitating enhanced productivity and performance within an institution or organization. And that can apply both in the context of an institutional setting, such as the Children's Hospital of Pennsylvania, which I've had an opportunity to work with, and coming to understand the nature in which they deploy mHealth in multiple facets, ranging from communication, through care management, through care integration on and off-site, as being means of enabling that level of engagement in that continuum of care within the institution and organization. It is also, however, a means of direct communication and communication between the patient and the caregiver in both a structured and unstructured environment, and again, really focusing on the preemptive component of mHealth as a means of sustaining health, wellness, and quality of life for the individual as necessary components. And it also becomes, I think, in its essence, again, a means of considering models of care and means of delivering care in a more dynamic, interactive construct, which ultimately can facilitate a level of engagement and involvement in health on the part of an individual that has previously not been experienced. And I know, again, from the sessions that I've been party to today, that notion of health is focused a lot, if you will, on the front end. Fitbit, exercise management, weight management, food intake, balanced nutrition, all of which are very important and really essential to long-term health. But I want to share, I think, a different perspective, which is what can happen with regard to patient selection and engagement on the chronic care side and the ability to demonstrate enhanced outcomes both clinically and financially with that population, which again I think enhances the overall continuum and the overall breadth of application as it relates to mHealth, but also I think reinforces a critical component. That is how one structures the intervention, the nature of that intervention, the manner in which one mobilizes data, information, and analytics to support that intervention, and the patient selection and engagement which then goes into that intervention all become critical elements in defining, if you will, the ecology of an mHealth deployment and engagement within the healthcare system. And I think those elements are one of the reasons that as we look at the literature today as it surrounds mHealth, there are many examples of the benefit mHealth can deliver, both from a chronic care patient basis as well as a post-acute care management basis. But there are also, as was the case which was recently shown with regard to the article in terms of dealing with the medical home, of which mHealth is a critical component, that there may not be the savings that individuals expected. And in fact, post-institutional care may be no more cost-effective than institutional care, as was shown in the study that came out earlier this week. So those are the factors and the framework around which I'd like to see us consider mHealth for this session, and also then as we look forward in terms of issues of development and deployment, both here in the United States and in other countries around the globe. Thank you.
Thank you very much, John and David. Excuse me. This one to more.
That's my deck. Oh, okay. Here, let's do this.
So while they are sorting out the technology, I think in this meeting of technology, we had similar problem in the meeting that I will be talking about. So John had asked me to report on a meeting that we recently organized in Dar es Salaam 2 weeks ago. It was on the use of mobile technology to improve family planning and health programs. And I want to give you a little bit glimpse. It is here, I think. How does it move forward? Yeah, here we go. So we organized this meeting in Dar es Salaam, and 15 countries attended from Anglophone, Lusophone, and Francophone countries. So I'll be talking about briefly as to what is USAID. I know everybody knows, but John asked me nonetheless to say something about USAID. Then about the context of this meeting, why we organized this meeting and how we organized this meeting, and then what the countries reported as the use of modern technology or mobile technology, what their plans are going forward, and what are the challenges that these countries are facing. And interestingly, you will find that the challenges are very common between the developed and the developing countries, so there is a convergence here now, and what are the next steps. So USAID, I think we can say that the mission is to advance broad-based economic growth, democracy and human progress in developing countries, and human progress includes science and technology, environment, innovation, and so on. But the ultimate goal of USAID is to create conditions in which U.S. assistance is no longer needed. That is, the focus is on the development of the capacity in the countries. So there are these two major goals. One is the advancement, and the other is creating the capacity in the developing countries itself, so we get out of business. And so I would like to underscore these 2 points, because what I'm going to talk about next, that is the process of organizing this meeting, to some extent serves both these purposes. That is, a focus on technology as well as creating capacity in the countries. So the meeting that we organized, this is the third in a series of meetings with what I call is a new kind of meeting. Why new kind? Because we, USAID and other donors together, provide the platform. But it is the countries that drive and lead the whole process of organizing, chairing, and talking at the meeting. So each country which intends to participate in these meetings forms a country team. And the country teams consist of governmental, non-governmental organizations, as well as, in some cases, the private sector, all the stakeholders. They spent several months in preparing for the meeting. They map the conditions, what exists, what are the issues. They interview people, the focus group discussions with the communities, and then they also have discussions among themselves as to where they want to go. So they come to the meeting fully prepared, and the way the meetings are organized is that there is no lectures from any expert from outside. It's the country team that exchange the information, ideas among themselves, because the main focus is on implementation. And the view is that who knows about implementation problem better than those people who are implementing themselves. So there are experts actually in the first meeting. We had a number of experts, but they were sitting at the back and they say they are out of business because nobody was called upon them to intervene and discuss and so on. So it was entirely driven by the countries themselves. They exchange information, they were thoroughly engaged, and since the panel discussion and the discussion in the session does not cover everything, they also come prepared with posters and all types of display materials which they display in the booths, which we call gallery walk. So there is also this gallery walk for in-depth discussion. So at the end of the meeting, they are prepared to discuss as to what they are going to do in groups or individually, and then they go back to the countries with the ideas, because they cannot take decision by themselves, and then they have their own work plan. So this, I would like to go back to this slide. Here we say Kigali to Dar. So the first time we adopted this process was in a meeting in Kigali, which was on family planning program in general. Then the country team there decided that they would like to have a meeting, and they decide what is the topic on which they would like to have the meeting. So the next meeting they decided would be on effective community approaches. That was the major issue that came out of the Kigali meeting. So they had similar meeting in Nairobi, and then they had further discussion in Dakar, and there they decided that mobile technologies and other area which they would like to discuss. So we had this meeting in Dar es Salaam a few weeks ago. So that is why we say that Kigali to Dar, and we trace the progress from one meeting to the other as what happens in between. And when they go back, then it is followed by country visits, exchanges, and so on, so that it doesn't end with the meeting, it continues over the period of time. So here, I think the purpose of this meeting was to share, as John mentioned, promising practices with respect to use of the technology, and also how to scale up. Those were the two main themes at the meeting. So here what came out, here I think it's very small print, you would not see, but I would like to just highlight 3 points in this matrix, that this is the pattern of use as reported by the countries. So you will see that mainly it was the information technology which was used, and in 3 areas: logistics, particularly commodities, management, and communication. And you will see half the countries used it for service delivery or for manpower, and fewer countries use it for financing or monitoring and evaluation. So what it really shows is this, that at the initial stages, and these were mainly pilots, I think that only 3 or 4 countries were going to scale up or were in the process of scaling up, such as Madagascar, Kenya, Rwanda, and I think, yeah, these are the 3 countries that were in the process of scaling up. So here you will see that fewer countries using service delivery or manpower is because of the fact that the focus was mainly on information technology. There were very few examples of other devices. So the next point I would like to make is that what are the examples of innovative technology that came out at the meeting. So first I will say that Madagascar, I think Airtel had a very interesting program, 3-2-1, that is they gave free time, and there was there were lines available and people could call. If you press 1, you get certain type of information on contraceptive. If you press 2, you get the direction of the clinics and so on. Then the other one, you see that Uganda was using Skype for training purposes. And then also you will see that here that Madagascar was also using what they call data winners. That is, they had cloud communication technology, and anybody could report on the progress on certain types of activities anywhere, and they will then make it a part of the database. Then Tanzania, I think there was very interesting use of technology where they combined the mobile money technology with mobile health technology, and this called the Center for Community Rehabilitation in Tanzania, and there they were using for fistula patients. So they will transfer money to a focal person in the community who will arrange for the transport, and the person will be transported to the central facility where they will be treated. And Kenya was using M-Pesa for, this is a sort of a smart card. They were using for savings as well as dispensing money. So there were some of these uses of mobile technology, particularly information technology, for reporting and for communication. But here these two, you will see they combine mobile money technology with mobile health technology, and these have been very effective. So where the countries want to go from here, I think all countries thought that advocacy is needed in their own countries to really convince the government and the private sector and other stakeholders for extensive use of mobile technology. Then 3 countries decided that they wanted to 3 countries, Burundi, Malawi, and Nigeria, decided to develop the national strategies. 4 countries were very keen to develop private-public partnership: Democratic Republic of Congo, Kenya, Madagascar, and Nigeria. Then several countries wanted to evaluate either their progress or do the assessment as to what exists in a systematic manner. And the scaling up, I think that Madagascar and Tanzania had a very firm plan to scale up the technology that exists, the best practices. But the part of costing, we were very surprised to find that only Malawi and Rwanda are trying to cost the plan, which is so important in order to scale up. So what are the challenges? As you say, that most countries are at early stages of adoption of modern technology. It is only mainly information technology they are using. But I think that the next step is that the scale up should be the focus, and scale up for adopting universal health coverage with modern technology. And I think this is a common factor between the developed and the developing countries, that all are trying to attain universal coverage, and this modern technology which is going to play an important role in achieving that goal. And there are 3 points in adoption of modern technology for universal coverage which are extremely important, and which modern technology can certainly be used. One is to reduce the health cost. The second is provide effective community outreach. And the third is to adopt financing mechanism such as health insurance to attain sustainability. And you will see that here the whole world is together in these 3 areas. And I think that there is a lot to be gained by exchange of information and ideas, and constantly watching as to where the world is going. So we thought that as the next step to address these challenges, it is important to share ideas, information among the participants, certainly through the listserv. But also I think that we should have exchange of information not only among the developing countries, but between developed and developing countries on these areas which I just talked about, that is the cost reduction, insurance program, and incentives to facilitate the private sector to work together. And that is what we intend to do. Thank you.
Thank you, Shred. Mira?
Thank you very much, John. I asked John's permission not to get up onto the pulpit and speak from there, and instead to make some comments just from here. So I hope you'll bear with me. I work at the World Bank, as John said, and quite honestly, currently, the bank's investments, I won't go back into talking about what the bank does. The bank's mission is poverty reduction, a big picture mission. Our focus on the Millennium Development Goals, and as you know, 3 or 4 of the MDGs are linked to health, so that's why we are here. We have a new president. What has he asked us? What has he challenged us to do? Bend the curve, bend the arc of development. It's very clear that the world is not going to achieve most of the MDGs, the Millennium Development Goals, that are supposed to be achieved by 2015. But he's urging us, and he's somebody, Jim Kim, who some of you may know, has a background in public health. And so he's pushing us to say, there is still time between now and 2015. Can you do something else to move this agenda forward? So as we think about moving things forward, what are the issues you want to think about? You want to think about things that could be transformative. And what could be more transformative than technology, new technology? You heard this morning from several people about how technologies can be disruptive. Think about the fact that in 1990, when the MDGs were conceived, there were, as Jeff Sachs said, 10 million cell phones sold in the world. 2012, 2013, there are 6 billion cell phones. Has it been transformative? Has it been like a disruptive technology in the world? Yes. And think about the fact that the Millennium Development Goals were also set from 1990 to 2015 to have a major transformative impact. We haven't been able to achieve that, but the technology to do these sorts of things has actually scaled up dramatically. And I think, quite honestly, we at the bank, as well as several of the other organizations, have not been as nimble in taking advantage of these technologies. So we still have a little bit more time, and certainly a post-MDG agenda where we need to work on these things. I was reading this morning on one of the blogs that cell phone sales are going to slow down. Gosh, this year only 1.7 billion cell phones will be sold. What a pity. You know, if we could ride this wave in development, in global health, we could have a major impact. I could talk about specific things that the bank does, but instead of doing that, based on some of the conversations I've had with several of you this morning, what I'm going to talk about is the big picture of how the bank engages in this agenda. First, to clarify, the nature of our business is a little bit different from what is being discussed in the mainstream here. We're not customers. We don't buy technology solutions for ourselves, except for bank staff, but that's a whole different ballgame, and I have no clue how that happens. There's a whole different system for that. What we do is we liaise with governments. We work with developing country governments to develop policies, strategies that then provide the enabling environment to do the sorts of things that are being discussed over here. So that's the context. We provide countries with technical assistance. We invest in countries. For us, investments of 20 million, 30 million, $100 million is usual in countries. But we invest in health systems. And within those health systems, as I said earlier, it's very important for us to be transformative, to start riding this wave of technology in a more systematic way. As we think about including these sorts of technologies in our investments, what are we looking for? We're looking for innovation. Everybody at this conference is looking for innovation, so that's nothing new. We are looking for that too. We're looking for scalability. You already heard from David about scalability and how important that is in terms of sustainable models. But for us, it's important not just for the profit side of it, it's also important because scale is what will bring impact at global level or national level. So we really look for scalability. But as we look at what's happening in terms of challenging scalability, we are amazed by, well, not amazed. In some ways, I guess it's natural that the first many thousands of innovations are innovations that are standalone innovations. One innovation for malaria, another innovation for TB drugs, a third one for nutrition, a fourth one for HIV. Well, in good conscience, we cannot go to governments and say, you know, as part of your public health system, you should put this one for malaria, that one for TB, this one for nutrition, and that one for something else. What we need to make sure that these systems speak to each other, that issues of interoperability and all of those things that you all have talked about ad nauseum in the other sessions, I just wanted, that is absolutely critical for us. I was in Uganda a couple of months ago, and I was amazed by a map of Uganda. If there was one slide I wanted to show, I should have brought with me, it would be that one. A map of Uganda with a disease called pilotitis. Over 55 pilots. Every district of Uganda has a different pilot. None of those pilots speak to each other. I wonder if somebody from Uganda is here, and maybe they can talk about it. Same conversation came up in one of the other sessions with the team from Nigeria. They said, you know, every donor, every institution comes along and brings their own special software and their own platform and their own device. Think about the fact, if you're looking for scale, and if we really want to do what Jeff Sachs was asking us to do, give a mobile solution, a mobile phone to every community health worker. Ethiopia just hired 30,000 health workers. If you want to give each of them one for TB, one for malaria, an Android for TB, I don't know whether that is correct, I'm just speaking. But, you know, a simple cell phone for something else and something else for something, we'd be bankrupt. Countries would be bankrupt trying to set up systems like that, and they wouldn't work. And they'd have to be in constant training just to be able to use those tools. So it's just a reality check that we need to do these innovations, but we also need now to start thinking how we can link these things so that we can go beyond this fragmentation and pilotitis to a scaled-up model. I'm going to finish quite soon because I know we want to have some time for questions. It's good? Okay. I'll take another few minutes then. Another thing we need to think about is we are working in developing country contexts. Internet access is limited. There are more cell phones than toilets in many of these countries. Can we use very simple technologies like cell phones rather than complex technologies that need serious back-end investments? That's another thing. Can we, as David was saying earlier, if you're using these tools just to embed an mHealth component into a project, it's not going to be successful. But if we can use these tools to improve the efficiency of health service delivery, we can have major impacts. There was a study recently done by the bank that shows that an average physician, an average doctor in I forget, was it Tanzania or Uganda, in one of the countries, spends on average 29 minutes actually seeing patients. The rest of the time, he or she is busy doing other things. And there were some conversations this morning as well about what can be improved in terms of those other things. The service delivery part of it can certainly be changed, and e-health tools have the opportunity to do that. So when we are looking for fixes that we can help scale up in these countries, we are looking for systemic fixes that work across diseases, fixes that work across health workers, community health workers, next-level health workers, fixes that, for example, fix supply chain management issues. Drugs go into the system, Sometimes they arrive at the other end, and sometimes they don't arrive at all. The number of health facilities I've visited where either the doctor is absent or the shelves are empty in developing countries. Can we fix that through mHealth technologies? Of course we can. Supply chain management. The bank has one investment in Zambia, a small pilot. We do pilots too sometimes. That's trying to develop a supply chain management system with technical assistance from Zara, the clothing company, Zara, and because they figured out how to do better inventory control than perhaps some of the drug or medical systems in developing countries. One area that I have, actually there are two areas that I have not heard enough about in this conference and that are of very strong interest to us. One is around what we call governance and accountability, including things like supply chain management and tracking drugs and so on and so forth, and addressing issues of absent doctors. In Bangladesh, there was a study done that showed 40% of the doctors are never there where they're supposed to be. Can we not come up with mHealth solutions for that? Yes, we can. Even their cell phones, you put an app in there that will track whether they are, where they are and when they are. It can be done. Simple things like that can be built into larger health programs. But I haven't heard enough about that over here. Perhaps it's less of a problem for the developed world, but it certainly is a very big problem. Tracking drugs, tracking doctors, tracking health workers. That's a very important part. And we realized that in making those changes, as was discussed this morning, there are many, many barriers that lie within the institutions themselves sometimes, and many, many vested interests that need to be addressed. But we've got to go beyond that so that we can come up with a solution. The other, and I will stop after that, the other area that we haven't heard enough about is costs and evidence. We don't know, was it yesterday or I can't remember, or a conversation I had with somebody last week. We don't know whether just a simple paper solution is just as cost effective as adding an iPad or a mobile phone or not. We often do not know that. We just assume that, but as in our role as the bank where we give policy advice to governments, we need to have evidence that, in fact, this will be cost-effective and will improve the efficiency of health service delivery. Once we have that evidence, we are much more enabled to make that case with the governments and to go from there. I want to end with two other things that were discussed this morning. One is, well, just let me end with one thing that was said this morning, that small innovations, which we see are happening at the moment, and this conference is a classic example of showcase of many of those small innovations. What we need to make sure is that these small innovations can be built into an integrative system that we can scale up and that can then become a tsunami for change in the healthcare system. And as the World Bank, our comparative advantage is not in doing pilots, though as I confessed, occasionally we do them, but our comparative advantage is really in being able to take successful integrated pilots to scale. Thank you.
Thank you, Mira. Thank you, Mira. David, you're going to use the... Let's make sure to get David's slides on the screen. Thank you.
Well, hello, everyone. It's a real honor and privilege to be here today to talk with you a little bit about the mHealth value chain. I am Chief Medical Officer of SAP's Healthcare Division. And, clearly mHealth is hot. Look at this conference, those of you who've attended the last couple of years. It's just amazing to see the transformation that's taken place. tracking investments in small and emerging companies. If the current run rate holds, about $800 million will be spent by venture capitalists in 2012 on mHealth. Looking at established companies like SAP, we have multi-year, big investments on mobility. So truly the question becomes, the multi-billion-dollar question becomes, what part of that will stick? What part has a sustained ability to transform healthcare in a positive fashion? And what part will end up being historic footnotes and ascribed to a frothy market? And so I think using the lens of the value chain is really helpful in really taking a look at that. So that's what I'm going to do today, walk you through it. For those skeptics and those of us who've been around the track a few times and seen a lot of hype, we've never really seen an era like today. The financial challenges facing healthcare, we're all very familiar with them, so I'm not going to enumerate them. But what they're causing is a profound alteration in the DNA of healthcare, an openness to change that we've never really seen before. Areas of healthcare that have remained untouched for decades, if not generations, are now open and even embracing change. Now, I've got 10 minutes, so I can't go through all the mHealth value chain opportunities. It would make Michael Porter very disappointed if I were to attempt that. So what I'm going to do is focus on just a couple areas. In situations like this, I like following the Willie Sutton principle. He's a famous bank robber. When they asked why he kept on doing it, he said, because that's where the money is. So if you look at where a typical premium dollar goes, largest components to the hospital and the physician side of things. So I think it really makes sense to focus on there. And as a leading provider of analytics into the healthcare space, we have a lot of close relationships with really the top players across the payer and provider community. And I'm involved in many of the pilots and discussions. And what I can do is help give you the top 3 or 4 that I believe are really the key plays out there and save you the 100-plus hotel nights in a Marriott and 100,000 miles flying across the country. You can all do it from the comfort of your chair in the next 10 minutes. So a key driver here, and this is a huge thing, and it's going to take a slide or two to get into why this is so important for mobile, but I really believe it's worth the time. And that is payment reformation. It's the entire fulcrum around which this is all changing. Not only are we changing and beginning to pay based on value, but we're expanding the definition of care. In the past, we paid for a specific thing like a surgery. Of course, we're familiar with DRGs, which took that concept and said for an entire hospitalization or PPS on the outpatient side, we're going to give you one lump payment. And now what we're seeing, of course, is transformation to an episode of care, which includes all pre-acute care, acute care, and post-acute care. And even more interestingly, we are seeing management of chronic illness over time across multiple episodes of care and the desire to really pay one amount for that entire thing. Now, what this is causing, of course, are really challenging contract negotiations as payers sit across from providers and they try to figure out how to distribute the risk. In the past, this has been a very asymmetric process with the payers really having data and understanding that providers didn't. A decade ago or so, we went through the capitation road, and that was a journey that many providers don't want to repeat. They really didn't have a very good experience of it. Many of them didn't end up coming back from the journey. So the question is, what's different this time around? And looking closely at the analytic market, a lot of leading providers have really taken the opportunity of digitizing around the EHRs and then putting the necessary investment in to get a look across their entire IT infrastructure. So really taking a look at not only their clinical systems, but financial systems in an integrated fashion, such that for the first time for many of them, they're able to understand what it takes to what the cost is related to caring for a patient, for a particular illness, where variances are, and really the baseline, what I'd call the base camp of analytics, to really begin to understand and manage themselves actively. Of course, there's other efforts going on as we form ACOs of doing this across organizations, but what's happened, which is very, very profound and happening in the marketplace today, and it's going to drive mobility in a major way, is this shift in analytics from being something like this, where you have managers in a corner office looking at how did we do last quarter, last year, making necessary changes and then being done with it, to something that is becoming more real time. Because as long as you're going in a straight line, and healthcare had been for quite a while, looking backward is okay, looking in the rearview mirror. But we're entering into a series of, twisties in terms of racing analogy here, and a lot of hard turns in healthcare. So folks looking backward, what worked last quarter, last year, is not going to work anymore. Now, as a result of that, folks have been investing. Excuse me, I'm just going to grab some water. Thanks. So folks have been investing in technology to allow real-time analytics. And not only real-time analytics, but predictive analytics to help them understand what is happening in their business right now and what's likely to happen based on history. And that is a really profound transformation. And as this is occurring, what we're seeing happen in the marketplace is the realization that, as a manager, it's great that I know what's happening, but I can't communicate quickly enough to the folks actually delivering the care and making the decisions in the management of a hospital or delivery network. And so what's really needed is the ability to inform the entire staff, the folks in the front lines making those decisions in a real-time fashion. And, of course, what do we have with us at all times as providers rendering care? Mobility. Mobility is absolutely fundamental to this democratization of analytic information. The ability to take information, knowing what's going on real-time in the organization, predictive knowledge, funneling it all through to the right person at the right time so they can make the right decision, and doing this across an entire enterprise. Now, enterprises who do this well will have an incredible competitive advantage in the new world of payment reform. And they will not even be looking at just surviving, but they will be thriving in the new era in terms of being able to capture market share, because they'll be able to practice much more efficiently than folks who are not doing it. So this is a huge opportunity that's evolving in healthcare, and that's going to be very, very large scale as it occurs. Now, all of this is talking about what's happening within traditional delivery within the four walls of a hospital or a clinic. And it's important to get that efficient, no doubt. But the challenge and the real opportunity to move the needle is beginning to engage patients on a more continued basis. When you look at healthcare spending, it's incredibly nonlinear in its nature. About 1% of the population is responsible for about 27% of the spend. It's very disproportionate. And treating these people when they get ill reactively, when they come to a hospital or a clinic, is like fighting fires rather than beginning to figure out how to prevent them in the first place. So the shift is going to be to population-based management, and how can we get providers to do that? Now, this is not new news. We've tried it many times in the past. The challenge is when you talk to providers and you sign them up for this program where they can make more money for doing proactive care, what happens is they sign up and then they look at it and here's their practice. Where do I start? Right? Because when providers think of their practice, they're really thinking of the patient in front of them. They're looking at their list of patients they're going to see throughout the day. And when they start to look at it as a population, they don't even know how to do it. Now, fortunately, payers are very, very versed at managing populations, at risk stratification, population definition, care engines, care opportunity identification. And one of the big projects we're working on right now that is very promising is taking that information that payers have and digesting it, filtering it, displaying it into practice digestible components so that they can, with a modest investment of a person in their practice, spending some time on it, know who they can talk to and what they can talk to them about to actually begin to proactively deliver care to this very, very important segment of the population. So that's item number 2. Now that, of course, will lead to anyone else, anyone here who's involved in the frontline delivery of care saying, well, that's well and good. But we all know that the last mile is often the challenge, and that is even once you're able to fire the perfect shot, identify the patient, give them the perfect care plan, and deliver it out to them, the challenge often is and falls down on that of adherence and getting the patients engaged and actually to execute the care plan. And that leads me to the third area of opportunity in the value chain, and that is in patient engagement. When you look around, just whether you're traveling, any downtime people have, it's like this, right? Everyone's on their mobile device engaging in various aspects of their life. So this is a huge opportunity. People are very hungry for knowledge around their own health care, and so providing a tailored care plan to them with vetted information related to their illness and pulling in biometric information so they can see how they're doing against plan are all very powerful techniques to help begin to have a person engage on an ongoing basis in their own health and wellness. And that's good. But the challenge is, even with the gamification aspects of it, the change is somewhat limited because a lot of what we're asking them to do are lifestyle changes, which are hard by definition. So one area we're particularly excited about is in leveraging social media to pull in friends and family to help make a difference. So one of the challenges from a practice perspective is they just don't have the personnel to be in touch with these high-spend, high-risk individuals on a multiple time of the day. So what you can do is group source it out, so to speak, to people who are in the patient's life. And when you look at patients, in general, every patient has a disorganized social network around them of people who care about them and want nothing more than to see them healthy and doing well. They just don't have the means to be able to do it and understand it. So in leveraging social media, what you can do is allow the patient to grant access to people they trust to begin to help them make those difficult changes. These people in their lives have the presence to know what's going on 365 days a year often, and also the permission to be able to ask those difficult questions that I can't really do as a physician. And so that, to me, is the third emerging area. Mobility is just a natural solution there. It's what people are using. And this is going to be an area, if you really want to talk about bending the cost curve, it's getting the chronically ill patients engaged in their own health and wellness, getting their supportive network engaged, because you'll never find a group of more motivated folks than the people in their lives who really want them to be well. And the last area is that of the actual management. And this is actually in flight today. There's, we certainly have a lot of interest in tools that we're working with clients to field, and that is in managing devices. This is interesting. This slide was only from about 3 or 4 years ago, and those of you who are sharp-eyed probably noticed there's a BlackBerry there. Back then, that's what you'd use. I mean, this was hip. This was it. It's a Blueberry, right? When you look at what's happened in the last 3 or 4 years, you've seen that their market erode and RIM's market share. Apple take off, which wasn't a big surprise, but there was this upstart back then called Android, right, which, what are the chances they're going to compete against Apple, which now actually is the largest device shipped out there. So you have this challenge of the reality of a bring-your-own-device network. It's too expensive to pay to field devices, and people don't want them anyway because we have our own device we're used to. So organizations have to figure out how to, in a secure fashion, be able to provision apps out to not only their own employees but patients in a secure fashion, be able to wipe devices and do all those important aspects. And so this is an area where there's very much a market today. So, and that sums up my comments.
Thank you. Okay, now's a good time for you guys to come up and ask your questions. I've written down a few things. First of all, does anyone have any questions in the audience that they'd like to? No questions from the audience? Courage. Thank you. Go ahead.
So I found it interesting listening to the two women on the panel. And I think there's this issue of trying to be transformative, and then you move over to a set of conversations on the ground in the countries with the people actually implementing. And it's almost as if they couldn't, you probably didn't invite the people who over here who are talking about being transformative to that meeting because it wouldn't have made any sense. They couldn't even have spoken to each other. So I guess, one of the questions that always comes up is where do you get the innovation model to drive sustainability? Because it's not going to come, I don't think, from either of those sets of players. And I'd suggest that one of the largest sources that it can come from is an ecosystem called social enterprise. And it's a very large ecosystem that very few large organizations know anything about. And not only do they not know anything, do large organizations not know anything about it, but the people in the countries don't know anything about it. So both groups who need to find an innovation model don't know about one of the largest sources of the potential innovation to become sustainable. So I guess my question is, how do you change that so that those innovation models that are being developed by a combination of entrepreneurs all over the world who are social entrepreneurs, along with 35 roughly organizations who support them, like Ashoka, Skoll, Schwab, et cetera, How does that ecosystem get into those conversations so you can actually get sustainability and transformation?
So let me, Ishrat, you want to take that? So the key question is.
No, it's really excellent question, and we really struggled with that when we were organizing this meeting at DAR, and therefore we tried to invite like Acumen and other companies that are engaged in this type of activities to Dar es Salaam so that they can interact with the country teams, and there was so much interest by the country teams in what these organizations had to say, but unfortunately there were limited number of these organizations that we could approach and that agreed to go. And so what I am saying is this, that there is a great deal of scope, as you are saying. In this case, on a very small scale, we applied that and we found that there is demand. So the next step, what I am thinking, is that certainly this exchange of information throughout the world, so that I think the private sector, the public sector, all exchange information. And then the next thing I thought would be that at the regional level, at least, we try to bring them together, if not at the country level, in the first instance.
Let me try and address that question. First, in the interest of full transparency, my daughter works at Ashoka. I think I know a little bit more about that ecosystem that you described. But also to be transparent about that, first day when she came home and told me she had a job at Ashoka, I said, What is Ashoka? So clearly there is a disconnect between those two, actually those three worlds, as you described. The country, what's happening at the country level, what's happening in social entrepreneurship, high-level social entrepreneurship models and circles there, and then what's happening at institutions like ourselves. And clearly there is a need to bring those three closer together. But just to be pragmatic, I think I see the role of the social entrepreneurship groups as the groups that that take these transformative or disruptive technologies to the field, quote unquote, pilot those there in a responsible way and scalable way, and then take them to the institutions, both government and institutions like ours, that can help to scale them up. But to expect that the bank should get involved in doing what you folks do better is probably not a good solution.
Thank you. Next question.
Hello, thank you for a great panel. My name is Katie Miraj. I work for an organization called Altarum Institute, and we're a nonprofit health research and consulting company. We're mainly domestically focused. And my question is for David. Your very last slide, all of a sudden I was like, wow, I want to hear more about that. And maybe that wasn't, you said it was from a few years ago, but I wanted to know if you can speak to, and if other panelists have something to say too, particularly about the use of mobile health to support provider decision making.
Yeah, no, I think, it's an area that is of great personal interest. I still practice as an intensivist a couple weekends a month just to keep my hands dirty and make sure I'm realistic in my expectations. Decision-making is going to be a very big and evolving area. Right now the FDA, and the regulations around it are going to be really crucial. I think a lot of people are watching very closely as it. And I think you're going to see a big wave of development now that the EHR vendors have deployed out and got a lot of money from that. The question is how they're going to fund themselves going forward. So I think you're going to see a second wave of true value built on top of EHRs around the analytics and real-time decision making. If you look at Atul Gawande and some of the stuff he writes around checklists and really becoming more algorithmic, I think we're going to see healthcare shifting from kind of a artisan, I do it by memory, to I'm going to do it in a very algorithmic, team-based fashion, informed by a 360 group of caregivers around me. So big topic, but a quick answer. So.
Who else?
If I could add just one point I'll add to that. I think the other thing that you're going to start seeing, and I think this gets back into the whole notion of information enabling decision making, is the notion of decision making by exception. So the fact of case in point is one of the issues you get into with EMRs is what's called alert fatigue, is the fact physicians are always receiving alerts with regard to what is occurring with a group of patients or with the population of patients that they are treating. I think one of the things that we're starting to see is, as we take a look at the landscape, as the firm I'm with takes a look at the landscape, and as we look at different implementation opportunities, is really a fundamental change in the thinking with regard to how you manage a patient. And to manage a patient with regard to the exception to the rule as opposed to the rule. So it is really then coming to understand, because you have the information available, because you can understand variance away from trend as opposed to gross deviation, to then be able to manage on that exception basis where you don't have to know everything that's going on about every patient all the time. What you come to understand is what you see as variance off trend for that cohort of patients who is then experiencing that variance with prescribed means of intervention based on clinical algorithms and decision support capabilities that are then embedded, which, if you think about it, is very different from how we process care decisions today. So again, I think that's going to be one of the changes that you'll see going forward.
And actually, I'd like to add on to that, because I think, one of the challenges we see is so little medicine is actually algorithmic today. There is so much variation in practice based on training, based on personal comfort. And so one of the real work ahead of us as providers is to figure out what works best, and not just on an outcome basis, but on a value-based basis too. So what's the best outcome for the fewest investment of dollars? And then for a lot of us, relearning how we practice to really standardize on that. And then once you have that, it becomes more possible to have things algorithmically driven. But so many areas are so stick-built every single time that it's hard to get a lot of rules built in and around it because there's just too much variance.
Okay, we're going to go to the question in the back, and then we'll take you the question.
Thanks, John. John Melling from Top Tier Consulting, and also from the Medical Banking Financial Systems Committee. Hi, John.
Good to see you.
Some very good thoughts and observations today. Thanks very much for that. And you almost got to my question in the last answer, but I think if we're looking at a comparison between what we do here in the US and what needs to happen in sub-Saharan Africa, for example, in third world countries that don't have the infrastructure that we do, if I was to be very simplistic about it, I would argue that we are choking with data here, and we talk about big data, and so we need big systems to chew that and make sense out of it. If we're dealing with poor countries that don't have the infrastructure, then trying to interpret that in the way that we think about it in the US is completely wrong. We can't put in large EMRs because they don't have the infrastructure either technologically or physically. They don't have necessarily all the expertise. And so in those situations, we might be able to skip a generation and work more appropriately with personal health records, for example, and systems that are more nimble in addressing the absolute needs that we have. And maybe we go back to post-war England, where we were dealing with chronic infection and disease that we had to address. And we're doing that in some of the African countries now. And I'd be very interested in your thoughts as to whether I'm on the right track or whether I missed something, because I think we are in danger of trying to choke other countries with the same kind of profiles that we've adopted here.
Okay, just a very quick response. I would agree with you. I think in addition to the fact that we might, by trying to impose these so-called first world models onto third world countries that have very different infrastructure, in addition to, we would choke them, I would agree with you completely, but in addition to that, those are in some ways virgin grounds for many of these technologies. Here, correct me if I'm wrong, I don't know that much about what's happening in the U.S. healthcare system, but as far as I understand, electronic medical records that have been started they don't speak to each other. Each of them is a different vertical system. So we're already in that situation where life is much more difficult. But in developing countries, we can certainly start with more nimble, and that's exactly the kind of role we would hope that institutions like the bank, the World Bank, can play when we provide policy advice to government states.
Yeah, I think, that The solutions may be very different, but the nature of the problems are the same, as I pointed out in my presentation, that the reduction of cost, coverage, those are the issues which the developing countries are also facing, insurance coverage particularly, and developed countries are also. But the thing is that you are absolutely right, we cannot adopt the modern technology that is being used here in the developing countries. The answer is to let them develop their own solution to the problems, and that's what they are doing. And I think that is what we should facilitate, and then it will be most effective. But then we can learn from each other also, in the sense that what problems the countries which are far ahead in technology are facing, and how the countries with simpler technology have solved those problems. So that will be a great way to learn from each other.
Okay. Yes.
Well, I want to commend the speakers in the previous question, because I do think that the opportunity for us to learn from the global marketplace about something foundational as community capacity building can help drive the change in the United States. As I was sitting here, I was thinking about, I go to meeting after meeting on adoption of technology. We need a meeting on change and behavioral, cultural change, behavioral change, where perhaps the folks who are willing to invest money to speak to their peers and potential investors in the technology would be willing to invest money to bring together the people who can't afford to come to these meetings, but actually are the rubber that meet the road. And so if we could help them understand the value proposition that comes from adopting the technology and using it, and kind of train the trainer and build the capacity for adoption, then we won't have this reduction in spending. We'll have an increase in demand for the services that everyone's providing. So I think there's a lot we can learn from what we do in grassroots, community-based organizations globally, that for whatever reason, we haven't been able to kind of transplant and transpose onto our own culture in the United States.
Good comment, thank you. And I failed to tell people to make sure to identify themselves before they start speaking, and I'm sorry about that.
I did that on purpose.
Yeah.
I'm Carla Denise Edwards, the Bay Company, Zero Divide.
Thank you.
Yeah, great comment.
Yeah, we're going to go ahead and take the next question. Go ahead.
David Aylward from Ashoka. I would like to thank Ms. Shakar for the donation of her daughter to our organization. She's quite the star, and I'll give you your best attitude tomorrow when I see you. Just a couple of quick questions and then a comment to you. I think that the West provides a wonderful model for the developing world. Particularly the United States provides an extraordinary model for exactly what not to do in health. So from a technology from an IT architecture point of view, we are spending billions of dollars layering IT on top of a system that does not work, rather than designing a system of wellness and vitality, with sick care being the exception to the rule, where we focus on nutrition and clean water and so on. But you can build an IT system around people, around the person, and build from there, and not have to fight off GE Healthcare and Cerner and with due respect, even SAP, who already have entrenched relationships and structures that they are supporting. So there's a great opportunity in the developing world, and I don't think that we should necessarily say go ahead and do it on your own, because India is going as fast as it can to copy our system, and that's probably not a great thing. But the question I want to pose really is, Mr. Casillas, you and I met on the telephone several years ago and had many conversations. I don't understand why this panel isn't talking about a critical intersection, which is that of finance and health, because you can't run these health systems efficiently without finance, and 80% of the healthcare spend in the developing world is out of pocket. And I think these two systems, there's a lot of synergies there, and the World Bank could do an enormous amount by saying, yes, we will not lend to you unless you use IT, and two, unless you integrate systems.
Thank you very much for that comment, and I'm going to give you a gold star.
We got to take the next comment, but I do, Ishrat, you just heard what he said, right? So you know, they understand that there's a very important intersection there, but we only have a limited amount of time to talk, so. All right, so we'll go ahead and take the
Yeah,
next
I
question.
would like to comment. I think
Yeah.
that's a great question. That in general, what is happening in the developing countries is these technology uses on a pilot basis. So the financing issue is not on their radar screen. That's number one. Number two question is this, that wherever they have combined the financing like mobile money with mobile health. It's very effective. It's extremely effective, and these are the best practices that we really need to disseminate in order for countries to learn. But that's my greatest disappointment, that the financing issues are not getting as much attention as they should.
Actually, if I may add to that, thank you, Chris, for that comment. And my daughter is not a donation, it's an investment. We believe in investments. In terms of financing, clearly that's what the bank brings to this thing. I would never want to go the direction that you're suggesting, unfortunately, of saying to countries, we won't do this if you don't do that. That's not the New World Bank. We are a reformed bank with not really getting into conditionality, those dirty C word of conditionality. Instead, it's much more about policy dialogue and engaging and showing them why it's important to invest in these things and why it will improve the efficiency of their own healthcare system. So that's the sort of dialogue we would like to do. In terms of financing, you're absolutely right that to date in this area, we're still talking traditional financing models. This came up in one of the other sessions as well, that we're still talking about donors and recipients. We should be talking, this is the area we should be talking about in terms of innovative financing. If there is an area that is just crying out for innovative financing models, this is the area. And just to continue the family tradition, if you heard my brother Vinod Khosla speak this morning, he talked about how if you want to bring a change in any sector, you have to bring somebody from outside the sector, and maybe that's what's needed here. Thanks.
Yeah, I appreciate the comments on medical banking. We're going to take this one question because, just so you know, the people that came in, we were crowded out of our session, so we're going to take some of your time. I'm just kidding. Go ahead.
Thank you. My name is Ben Nardone. I work for a nonprofit called Pathfinder International, and we do development work largely in Africa. The thing that I'm struck by this year, as well as previous years, is the mantra is scaling up and sharing and collaboration. What I don't see is that reflected in the RFAs that we respond to. And I'm thinking specifically about like intellectual property, where we're going to be doing, we're doing text messaging and we're developing IP there, but we're not called on to donate that back at the end of projects. Similarly with data that we may collect, similarly with plans to scale up. And I'm wondering what the role, what if any the role is, and I guess what the current state of collaboration among the larger funders is to sort of prioritize that during the awarding of grants and proposals.
You want to talk about that? You stumped us. That's good.
I was afraid you were going to say that.
Yeah, we know that, I think that, in this meeting that I talked about, we invited the Gates Foundation, the World Bank, IFC, and some other social entrepreneurs in order precisely to do that, because if we put all our resources together, the chances of scaling up are much better than individually. And most of these donors are funding really the pilot program. They have not been talking much about the scaling up as such. So that is the next step. I think that there was a suggestion that we form some sort of e-health collaborative and bring all these players together in order to see how we can put our financial and technical resources to scale up the program. But this is the big issue.
Thank you, Esther.
Thank you.
Okay. Well, with that, we're going to have to end, but thank you so much. You've been a great audience, and we look forward to after comments.